we'll get started here in a couple seconds. I just want to confirm that we will be recording this, and that if that is uncomfortable for you, you're welcome to log off and listen to the recording. So thank you for joining us. We'll go ahead and get started. As same format that we've had all along. Today we have a little less attention to the chat as we go through the information, but we know that there will be some questions, and we will get to those questions once you put them into chat. But we have a couple less people from our staff watching that are usually attentive to that. So just know we will get to it, but we probably will be a little slower at getting to the chat, or it'll be at the end. So today we'll talk about some of the COVID testing updates. As usual, our Elena, our lead deputy, will talk about some of the new tools. Our partners, CCAP, licensing if they're here, Early Childhood Council will update, and then we'll have some time for questions. So I'll turn it over to Elena.
Thanks, Jane. Hi, everyone. Hope everyone's doing well. We've got a number of topics to chat about today. We'll start off, as always, reviewing recent case data trends for Boulder County COVID. We'll do an update on the Omicron variant and what that means for ECE providers. We'll spend a good amount of time talking about the updated Return to Learn. We'll review what the change was, and we'll also just go over how to use it and address some commonly asked questions that we get about using this tool in your facility. We'll briefly provide an update regarding quarantine exemptions for vaccinated children, now that children 5 and up are now eligible for the COVID-19 vaccination. And then we'll end and just wrap things up with some reminders and resources for all of you. Okay, so COVID-19 cases continue to rise in Boulder County after our last meeting. We then observed a brief decrease in cases from the Thanksgiving break, followed by a slight rise again, but to lower levels compared to what they were pre-Thanksgiving. Overall, over the last 7 days, we averaged 104 new cases per day in Boulder County. Boulder County does remain in high community transmission, but we are doing comparatively better than some of the surrounding counties, particularly those that do not have local masking policies enacted. Longmont, near and including Weld County, has the highest rate of cases of all Boulder County municipalities, followed by Boulder City, then Lafayette and Louisville. Facilities that have families and staff residing in these neighboring counties just should be aware that the rates of COVID in these communities are even higher than what we're seeing here in Boulder, so the likelihood that a symptomatic individual has COVID may be even higher due to the heightened level of community transmission in those counties. We did observe a particularly sharp drop in cases among 0 to 11-year-olds in Boulder County leading up to Thanksgiving. And there could be a few explanations, including that we saw an overall decline in testing the week of the holiday, so fewer cases were being detected. There could have also been less transmission due to proportions of, children and students being out of school or care for the holidays. This could also be attributed to increased use of at-home tests that don't get counted in county case data, since those are not reportable by individuals to public health. And there could be some emerging rising immunity due to vaccination uptake in 5-year-olds and above, and very likely a combination of multiple factors. So in short, we will just continue to watch these trends over the next couple of weeks, and it's very likely that there may be fluctuations.
I think I do at 12:30 with Kinders. Or was it something else?
Going for her because she's taking kids on a scavenger hunt.
Oh goodness! Just like I don't know.
Can you please mute your microphones? Thank you.
Okay, thank you. Let's go ahead and advance to the next slide. Okay, so here we look at COVID cases specifically associated with Boulder County childcare attendees and staff by week. And this data does include at-home tests that are reported to our team directly from you all. Cases among children are depicted in green and staff cases are in orange. The latest data week is still in progress, meaning we are still collecting case reports and determining case counts for the week ending on December 8th. Nonetheless, you can see that childcare associated cases in Boulder County continue to rise throughout the month of November before dropping during the week of Thanksgiving. And again, we'll see how much case counts rebound in the coming weeks. A few other updates, although these are not depicted in this slide. We have 3 open confirmed outbreaks in East settings in the county, but they are comparable to what we saw last spring under the Alpha variant or B117 when we didn't have masking required in childcare. And that's actually a good sign. So we have seen very large childcare and school outbreaks in counties with no masking with the Delta variant. So to be able to contain a much more contagious variant through mask use is a very reassuring sign that we are seeing a positive impact with our mask order. In 2 of the 3 outbreaks, the primary spread was within infant classrooms, where children are unmasked due to being under the age of 2, and there is much more physical contact compared to older age groups. So please ensure that infant classes are being extra cautious with our mitigation strategies like masking among staff and excluding ill children. We did have 1 recent hospitalization of a young child care attendee infected with COVID. The hospitalization was due to a severe response to their COVID infection, but they were able to be discharged home after improvement with inpatient treatment. Okay, so now we'll go ahead and give an update on the Omicron variant and talk about the potential impacts it might have on childcare providers in Boulder. So like we've talked about before, variants are part of the natural evolution of viruses and arise in areas with low vaccination rates and minimal mitigation strategies in place. So in other words, when you have a virus that continues to spread, variants are honestly a natural part of the process. And actually pause and please remind everyone to please mute. I really appreciate it. It can be quite distracting on our end. Thank you. So the Omicron variant, also known as B11529, was reported to the World Health Organization, or the WHO, from South Africa on November 24th, 2021. The WHO has labeled Omicron a variant of concern due to a large number of mutations, including mutations on the spike protein that have not been seen in prior versions of this virus. The science is still emerging on the impacts of Omicron, and it will still be at least a few more weeks until we have a better sense of how this will impact the trajectory of the pandemic and what impact it might have at the local level. Early preliminary evidence suggests a potential increase in risk of reinfection with this variant, and it appears that this variant also may spread even more easily, so having a higher level of infectiousness or contagiousness. Current vaccines are expected to protect against severe illness, hospitalizations, and deaths. However, breakthrough infections in people who are fully vaccinated are likely to continue to occur. It is still too early to know how disease severity may change with Omicron. However, even if Omicron does not lead to an increased risk of hospitalization, meaning even if it's not more severe than Delta or previous versions, it can still overwhelm our already strained healthcare system if lots of people become infected in a short amount of time. Okay, and as for the local response, we have identified 1 individual in Boulder County who has tested positive and was confirmed to have the Omicron variant. This individual had a recent travel history and likely acquired their infection abroad. BCPH was able to rapidly isolate the individual and contact their close contacts. Additionally, the Omicron variant has been detected in Boulder County wastewater, which may indicate low levels of community transmission beyond that single known case. So what can early care and education providers do? Fortunately, mitigation strategies such as mask wearing, physical distancing, hand hygiene, all still work against variants. But as these variants become more and more contagious, these strategies require higher compliance. So we really strongly encourage you to take this time before Omicron becomes more widespread to improve your compliance with masking, cohorting and distancing where possible, making sure your illness exclusion and return policies are clear. Otherwise, we could anticipate having some large outbreaks in childcare if Omicron does prove to be even more infectious than Delta. Additionally, eligible staff and children should be vaccinated when eligible and receive a booster shot 6 months after vaccination or even earlier if immunocompromised. Additionally, some facilities have implemented serial testing or weekly testing of asymptomatic individuals as a way to detect asymptomatic or pre-symptomatic infections in their early stages. If that's something you're interested in, you can always reach out to our Health ECE team and we can walk you through some options. And finally, the other potential impact for ECE providers would be potentially if we do determine that a positive staff or child is infected with Omicron, we may ask you to consider a 14-day quarantine for close contacts in that situation to even further reduce the risk of spread within your facility. So to reiterate, if you're a facility that has been leveraging one of the two shortened quarantine options, so 7-day with test or 10-day, we may ask you to consider 14-day if we do detect Omicron within your facility. Okay, now we'll talk about the change to Return to Learn and walk through how everyone should be using it and address some frequently asked questions. So at this point, everybody should be using this version of Return to Learn here on your screen. It has a Boulder County Public Health logo and the color scheme is different than the prior versions you had been using. So if your version does not look like this, please find this current version and start using it effective immediately. We can drop the URL in the chat in a couple minutes, but it can be found at www.boco.org. That's boco.org/return to learn. So as a reminder, the change that was made is that BCPH will now allow facilities to accept a single negative antigen test in place of a PCR. ECE is using this version effective immediately, and K-12 schools will start using this in January. Some K-12 facilities that have ECE programs have opted to delay the rollout of this version in their ECE program until K-12 starts using it, and that is completely fine if you're in that situation. Additionally, some facilities have expressed concern regarding using a rapid at-home antigen test. So some facilities have implemented a stricter policy for Return to Learn where only PCR or molecular tests will be accepted at their facility. So that's just a good reminder that, as always, you can go stricter than our guidance, but you can't be more lenient. So now that we've addressed this change, we'll take a minute to review how to use Return to Learn and revisit some frequently asked questions. Okay, so before we proceed, an important reminder that Return to Learn is only to be used for symptomatic staff and children with no known COVID exposure and who have not tested positive. People with a positive COVID test or symptoms after exposure follow a completely different protocol that BCPH determines when you submit a case report. Also, Return to Learn is to be used for both vaccinated and unvaccinated individuals, since vaccinated individuals can still become infected with COVID, albeit at a lower rate. So a common misperception is that Return to Learn determines when a symptomatic person can return to care. And this isn't true at face value. Return to Learn does not dictate how long an individual with symptoms needs to be excluded for. It just indicates when a person needs to have a test before returning to home isolation period in the absence of a test. What determines when a person can return is what's specified in the green box: symptom improvement, and they have met your other routine illness policies. So the actual language from the green box states, follow regular return to school illness policies if all symptoms have resolved or are improving. So what that is saying is that once symptoms are improving, a person can return once they are permitted to do so by your other illness policies, including how sick is too sick or other facility level policies that you might have, including exclusion criteria. The green box should not be interpreted as a green light to return to care. Return to Learn is simply the first step to see if a person will need a COVID test or not, based on the symptoms and how long they've lasted for. And then once they meet the green box, you defer to your non-COVID illness policies to determine when they can actually return. So now we'll take a moment to address some common questions or concerns that we've been getting. So first, some facilities are not comfortable with having people return with improving symptoms. This often comes up with runny noses, which typically don't have exclusion policies around that symptom in isolation. So as a facility, if you want to see complete symptom resolution before allowing someone to return, then you can implement that policy as a facility level policy. Demonstrating symptom improvement is simply the bare minimum that BCPH requires, but again, you can make your own stricter policy for your facility. Next, we've been asked if someone needs to wait 24 hours with major symptoms or 48 hours with minor symptoms before they get tested. And the answer is no. That is just the maximum threshold at which somebody is required to be tested before returning to avoid a home isolation period. Apologize, I shouldn't have said maximum threshold. It's a threshold at which somebody would need that test if symptoms haven't resolved in 24 hours for major symptoms or 48 hours for minor symptoms. So if you have a symptomatic person who uses those at-home or rapid tests to get tested right away and they get a negative result, then they've reached that green box and they can return with symptom improvement and upon meeting other illness policies. For example, for a child who wakes up with a runny nose and immediately gets a negative COVID test using a rapid test, they can return as soon as their runny nose improves and they have met your other illness or exclusion criteria to return, even if this is before 48 hours have passed. So just to reiterate, follow return to learn, and when somebody gets into the green box, then that's when you determine if it's symptom improvement or resolution and when they can return based on other policies. If somebody doesn't want to test immediately, they can wait to see if symptoms resolve in 24 hours or 48 hours for minor symptoms only. Unfortunately, in that situation, while that individual might not need a test, it will take them longer to reach that green box if they try to wait it out and see. And finally, we get asked if somebody who tested positive for COVID within the last 90 days should follow return to learn if they develop new symptoms after their COVID isolation is complete. This is a pretty nuanced area, and we will typically assess the situation on a case-by-case basis based on the unique characteristics of that individual's illness history. So if you have a person with a positive COVID test in the last 90 days prior to new symptoms, go ahead and reach out to us directly at Health ECE, and we will talk and walk you through your unique situation then. If you have additional questions about implementation of Return to Learn, please feel free to put them in the chat, and I'll be happy to address those during our Q&A portion. Okay, now we'll give a quick update on quarantine exemptions for vaccinated children. So now that children 5 and up are eligible for COVID vaccinations, we will allow them to follow the same quarantine exemption guidance that has been afforded to fully vaccinated staff over the last year. This means that any fully vaccinated child, meaning that 14 days has passed since the second dose of the vaccine, does not need to quarantine after an exposure to COVID as long as they remain symptom-free. While exempt from quarantine, exposed and vaccinated individuals should isolate immediately if they develop symptoms at any point and get tested for COVID-19. They should be tested 5 to 7 days after exposure if they remain symptom-free and retest if they develop symptoms after receiving a negative test result. And as a reminder, when you submit case reports forms to us, we do go ahead and provide all of these detailed criterion for quarantine exemptions in our response email to you. So as more 5-year-olds get vaccinated, and eventually once vaccination is approved for those under 5, there are certainly things you all as ECE providers should be thinking about. So first, it's important to understand the previous slide. If children get vaccinated, they do not need to be excluded from care if somebody in the class tests positive. While public health tends to focus on promoting vaccinations to prevent hospitalization and death, we recognize that the benefit of being exempt from quarantine is something that may be particularly compelling for parents. So if you are able to support this communication with your parents, please do help us make this message clear. If your child is fully vaccinated, they will not have to quarantine if a case exposes their class, and they should be able to stay in care without disruption. Along those lines, it will be important for you all to assess your capacity for partial quarantines. In other words, do you have the staffing to allow a small number of vaccinated children to attend care while their unvaccinated classmates are in quarantine? Keep in mind, while vaccines greatly reduce the risk that an exposed and vaccinated child may develop COVID, breakthrough cases can and do occur. So combining quarantine-exempt exposed children with unexposed classes could be risky if the vaccinated child has a breakthrough case. But at the end of the day, it will be up to you all to decide if you can do partial classroom quarantines, and if so, what that would look like for you and your facility. Okay, and we'll wrap it up with some reminders and resources. So our first reminder is that Local Public Health Order 2021-07 requires all childcare providers, both licensed and license exempt, including family childcare homes, to adhere to our required mitigation strategies, including masking for everybody aged 2 and up. The order also contains a requirement to report all cases to us, even if the positive staff or child was not present during their infectious period. That means if you become aware of a child or a staff member that develops COVID while on vacation or during home quarantine, we still expect you to complete a case report form to the best of your ability and send it in to our team. We are often asked why we need case reports for positive staff or children who may not have been present while infectious. Completed case reports provide critical information our EPI team needs to both provide effective disease control recommendations and track data trends in our local early care and education community. So first, for surveillance data, we use key data points from the form to track weekly case volume in Boulder County childcare facilities, which is our only source of data of this kind, and to assess trends over time. So I mentioned this earlier when we were looking at the orange and green bar graph, reflecting cases specifically in childcare. We would not have that data if it wasn't for these case report forms. The second is disease control. So we use information in the case report to protect your facility by providing accurate return to care timelines for children, staff, and any exposed siblings. And this is really important because, again, even if they were not in your facility when their infection first started, allowing cases or contacts back into care too early can expose others and initiate classroom quarantines. Finally, outbreak investigations. So details provided in the case report form allow us to track cases at each facility and to assess whether transmission may have occurred at the facility and help us determine when a facility has reached the threshold for a confirmed outbreak. So these are all really critical parts of our COVID response that do depend on these completed case report forms. We absolutely recognize that everyone's busy, and particularly when you have multiple cases in your facility, it can be a bit cumbersome to get these over to us. But this data or this information is critical, and we wouldn't have access to it without your cooperation. So we do just want to thank you all, and hopefully allowing you to better understand how we use that information can kind of help answer some of those questions about why we're requesting all this information on multiple people. Moving on, another frequently asked question that we're getting is, can at-home antigen tests be used for 7-day quarantine? And the answer is yes. So if your facility accepts a shortened 7-day quarantine for symptom-free, unvaccinated, and exposed individuals, an at-home antigen test taken between day 5 and 7 after exposure is acceptable for a return on day 8, assuming that's negative, of course. As always, your facility can implement stricter policies, such as only accepting PCR, molecular, or proctored antigen tests if that is your preference. Finally, we just have a screenshot here of our tips for a safer winter break guide, which is our guide for early childhood education families and staff. And we have an updated version for this year. We sent it out on November 18th, but it definitely still applies for the upcoming December and early January holidays as well. So check your email from November 18th from Jane. And if you do not have a copy of this, please feel free to reach out to Health ECE and we can provide you with one.
Thank you, Elena. And we will get to questions. I just want to give the partners, CCAP. Sounds like someone has unmuted their microphone as they chat. But do we have Jody or someone from CCAP that would like to give an update?
Hello, yes, I'm here. Thank you so much, Public Health, for all that great information. The CCAP team is so impressed with all this coordination and grateful for the whole ECE community just kind of following up and doing all this extra stuff to keep everybody safe. And then, of course, just the awesome care that you provide to the families in the community. I just threw into the chat a link to our website, which has some new updated forms, which are great for providers and for families. We have the DocuSign packet that a family can initiate to do all of their application documents online and submit all of their necessary verifications online. They can also email us at ccap@bouldercounty.org, and we're happy to reach out or mail applications when needed. Also on the website, there is a provider section where you can report if you're having any issues with unpaid parent fees, or if you need to request an additional care needs rate. I want to wish, the whole CCAP team really wants to wish everybody a happy holiday season, and thank you for keeping everybody safe.
Thank you, Jody. And same to you for all of your work. Amy Carlo, are you here from the Early Childhood Council?
Yes. Hi, and I want to echo what Jody said. Thank you, everyone. We are just so impressed with all of the work that's being done and happy to be here at these meetings. Registration is still open for our 2 EQUIT cohorts, expanding quality infant toddler care, that are starting in January. Spaces are, the registration has been going really well, and there's limited spaces available. So if someone on your team is interested in participating in either the Tuesday cohort or there'll be a Saturday cohort as well, I would encourage them to register. And we also have our financial incentive application period for college courses taken in summer and fall. That will be open in January. And information is on our website as well. It will go out in the training calendar. And also wanted to just spread the word about the Back to Work Early Childhood Education Scholarship Program. They are accepting applications. If you or someone you know who's been impacted by COVID and want to continue college to earn a degree or certificate in early childhood education, the scholarship might be a good match. We will have information sent out to everyone in the training calendar and as well as in electronic flyers as we spread the word about that. But please reach out if you have any questions or like any more information. Thank you.
Thank you, Amy. I don't know if we have anyone from licensing or if there's any other community partner updates. All right. And before we open it to questions, I'll just leave this on the screen so you can mark your calendars for our next meeting, which continues to be the second Monday. And we will, as we end 2021, we'll plan for January 10th as our next meeting at noon to 1. And I've put the Healthy CE COVID@bouldercounty.org email on this last slide. And I'll let Elena address the chat questions.
Thanks, Jane, and thank you all so much for your questions. I'm going to go ahead and start at the top and work my way down. So the first question is a great question. How reliable are the Binax at-home tests? And honestly, we really don't cite specific figures because, when we've done our reviews of the published literature, we tend to find that the test performance really varies depending on the study, the type of the setting in which the study was conducted. So we've seen sensitivity, which is the ability to correctly identify people truly infected with COVID-19. So basically the chance that it detects someone who's truly positive. And we've seen that figure range from the low 60s to the high 80s. But then, of course, that doesn't factor in user error. So in short, it's kind of hard to nail down a specific numeric figure for real world settings, especially for unproctored use of these tests. But we have to also consider things like ease of access to getting the tests. So while they might not perform as well as PCR molecular, we know that there are factors at the community level that do prevent people from getting tested. And so we kind of have to accept some loss in test performance in order to reach more people, get them the free tests, and try to really make regular routine testing a part of, very normalized routine when people develop symptoms. We have a next question, which is pretty similar, and honestly, a lot of the answer is going to be about the same. So how much more accurate are PCR tests compared to antigen tests? Another great question, and it's one that should seem like it has a straightforward answer, but it really varies. Now, there are lots of different PCR, molecular, and antigen tests on the market, and the test performance all varies by each test. And manufacturers provide data on the test performance, but then there's also real world testing data, which again kind of differs from study to study. So overall, we even if we're not putting an actual estimated figure or number to it, we do stand by that PCR tests are more accurate than antigen tests. But antigen tests, if they are being used frequently and by a significant amount of people, should be detecting cases, even if some slip through the cracks. So this is why we try to give you all leeway to determine if you're comfortable with accepting use of antigen tests for return to learn or for shortened quarantine or just one of those settings, or if you just want to stick with PCR and other molecular tests. And when I say other molecular tests, some of the more commonly used ones are Q, but these are tests that are typically performed in a doctor's office, although Q does have an at-home option. And we treat them as tending to be comparable to PCR in the sense of test performance, but they often can also be much quicker turnaround than PCR. So there are lots of options out there, and if you still have testing questions that we have not addressed at this point, you can always reach out to our Health EC team and we can talk through your very specific question. Moving on, the next question is the fever threshold still lower, or is that our facility policy of 101.5? So I'll address it from the COVID side, and then Jane, if you wanted to jump in or Kara from the regulation side, I'm happy to do that. But for fever, we definitely see children that are COVID positive that have reported feeling feverish, but haven't actually crossed the actual threshold for a clinically defined fever. So from the COVID perspective, we would absolutely love you to treat feeling feverish, regardless of what the actual measured temperature is, as a potential COVID symptom. So somebody who has been feeling feverish without a known exposure should use that as their starting point for a return to learn. Is there anything from a different perspective that Jane or Kara would like to add?
I would just add that you could always confer with your health consultant, your nurse, but that we don't have a regulation that states the policy, but I believe the 101.4 is actually considered a fever. I don't know if Kara has anything else to add.
Okay, we can move on then. Thank you, Jane.
Elena, did you want to talk more about the
I apologize. I was talking. I was on mute. That was my bad. I apologize. Let me restart, and thank you for your patience. The next question is, I thought my next antigen test came in boxes of 2 because a single test was not very reliable and you were supposed to test again a few days later. Is this incorrect? Nope, that is actually correct. And I do applaud this individual for being up to date on their COVID testing knowledge. Binax tests, the manufacturer instructions do specify that they should be taken twice with a certain amount of time in between the tests. And, I do recognize that BCPH has strayed from the manufacturer's recommendations, and other counties are not necessarily using Binax tests in this way. I know that that can, again, raise some concerns for some of our partners, which is why we always allow you to go more strict with your own guidance. But I do want to reassure you that this was an extensive conversation that we had over the course of weeks, if not pushing a month, with our chief medical officer, with other internal leadership and other stakeholders in the public health community. And we really just came to the determination that, well, yes, in an ideal world, we would have everyone test with PCR, or if needed, everyone would be testing following the manufacturer's directions from Binax. But in actuality, that just isn't the case. And there are significant proportions of our population that cannot access testing or are negatively impacted by having to keep their child out of care, losing wages for their income. This could be really particularly hard on single income households. And there are just a lot of socioeconomical considerations that we have to really balance with the risk of COVID. We really want to make sure that none of our mitigation policies exacerbate any disparities or inequities in the community overall. So we did not take this decision lightly, but we do recognize that we are straying from the intended use of these tests, at least for return to learn. And again, if you all are uncomfortable with that, you absolutely can choose to require PCR testing in either of the situations in which we grant use of antigen tests. And then there was a follow-up question, and we aren't expected to have proof that the test was performed or was negative. We just take the parent's word for it. Again, this is really where we're trying to give you all leeway to determine what makes the most sense for you, what you and your colleagues feel most comfortable with at the facility, and to determine what that process looks like for you. But we do not require you to have proof of test results. We never have, so that's really up to you all to decide. And if you really do feel stuck, you can reach out to Health UCE and we might be able to walk you through some ideas or options, but we really want you all to own that decision for what makes sense for you. Next question, if a child is tested positive within the last 90 days, can they be tested again during that time or will it be inaccurate? So this is kind of the gray area that we talked about a little earlier with return to learn. In general, if somebody is symptom-free, they've tested positive for COVID, but they've already completed their 10-day home isolation, typically we don't recommend retesting in an asymptomatic individual. And when it comes to a symptomatic person, so somebody who has recovered from COVID, they're still within that 90-day period, and then they develop a new bout of symptoms. Chances are most likely those symptoms are not COVID related. But we do want to walk through the unique scenario. One thing we'll do is we'll confirm the individual's test results through our state database. We'll take a look at, clinical documents if they've gone and seen a healthcare provider. We'll look at the dates that they were tested compared to the date that their symptoms started and try to make the best informed guess of whether or not we'll recommend testing or an evaluation from a healthcare provider. So in short, go ahead and reach out to us if you find yourself in that situation. And take a moment to please ask everyone to mute themselves. It can be very distracting on our end. Thank you. Okay, thank you. Next question, when 6 months, I'm sorry, let me actually just circle back to the previous one. I didn't make this explicitly clear. And the reason why this individual asked if they would be inaccurate is that some people who test positive for COVID-19 can continue to test positive. The longest testing specimen I think we've seen has been about that 3-month mark. But just because someone tests positive doesn't mean that they're still actively shedding contagious virus. So that's why there's some hesitation on retesting in that period, because we may someone might test positive, but it doesn't necessarily mean that they have an active infection. So that's the explanation behind it. Again, lots of nuance. Reach out to us if you're in that situation. Okay, on to the next one. When 6 months and up are vaccinated, will they be exempt from quarantine due to exposure as well, even if they are too young to mask? That's a great question. We have recently modified our language. We do not require masking to be quarantine exempt. I think there was some kind of some internal inconsistencies where we were following the CDC guidance to a T, but in practice, we are no longer, requiring that people who are quarantine exempt have to mask. Of course, under the public health order, everyone up to and up should be masking. Again, with the exception of people that have been vetted for a medical exception. Or medical exemption. But obviously, we never want those under 2 years old to mask. So in short, I believe we will probably allow them to be quarantine exempt, even though they're too young to mask. But we will probably come to a final determination as we get closer to that approval. Any inside scoop on when vaccines will be available for under 5s? I wish. I wish. And honestly, we really are just privy to the public knowledge that you all are seeing in the news. We do know that clinical trials are underway for those 6 months to, under 5. And so it'll really just be a matter of time for the clinical trials to kind of start gathering or analyzing their data, presenting findings to review boards, and then the process will escalate from there. But as of now, I'm not aware of an anticipated timeline. Just a thanks for the guide. It's wonderful. Thank you so much. I'm really glad that that has been useful for some of our partners out there. And then the last question I'm seeing is there any possibility that the definition of fully vaccinated may change soon to include the booster? These are excellent questions today. I'm really, really happy you all are bringing these to the table. The fully vaccinated definition is one that comes down from the CDC. We're not aware of any discussions in the works for the change, for a change. What I assume you're looking at here is, would people be considered fully vaccinated only if they receive a booster within a given period of time? And yeah, we're just not aware of any discussion that would be happening at the CDC level to change that. So for now, fully vaccinated still means 14 days have passed since the second dose of a 2-dose series, or 14 days have passed since the single dose of Johnson & Johnson. And if someone does not get a booster, they still are considered fully vaccinated indefinitely at this time. However, we still want to strongly encourage people to get a booster, especially because early research that's coming out on the Omicron variant may show that that booster really can help drive up the immune response to the Omicron variant, which might not be as effective with only the 2-dose regimen. All right, well, excellent questions. I don't see any others coming into the chat, but if anyone has any, I'm happy to address anything else that's on anybody's mind.
I'll give it just a couple minutes if you're typing in a question or you'd like to unmute and ask any questions. Now's your time. Maybe you've all just got it all figured out now. Just give it a couple more minutes. Thank you, Abigail. And thanks for all of your hard work from all the work that each of you have done to take care of our families and our children and our community. Like it's been said, you are essential. So not seeing anything but gratitude in the chat, which I really appreciate. So I will go ahead and close the meeting and give you back a few minutes to your day. Thanks, everyone. Have a happy holiday. we will be back for January 10th. Will be our next meeting. Thank you.